When most people hear Sjogren's causes nerve problems, they picture tingling fingers. Maybe some numbness. Annoying, sure, but manageable, something you mention to your doctor and move on from. What almost nobody pictures is a grown adult unable to walk in a straight line with their eyes closed. Unable to feel where their own feet are without looking down at them. Reaching for a coffee cup and missing it, not because of weakness, but because their brain has genuinely lost the signal telling it where their hand is in space. That's not a rare horror story. That's a documented, real form of Sjogren's-related nerve damage, and neurologists are increasingly warning that it's both more common and more disabling than the occasional tingling reputation this condition has among patients and even some doctors. Today we are going deep on Sjogren's polyneuropathy, what it actually does, why it gets missed for so long, and what real treatment looks like. If you keep leaving appointments remembering symptoms you forgot to mention, I made a Sjogren's symptom map to help you track the full pattern. Comment symptom map, and I'll send it to you. I want to be upfront about something before we go any further, because I think it changes how you'll listen to everything after this. This isn't a topic I'm covering because it's dramatic. It's genuinely one of the most undercommunicated complications of this entire disease, and the gap between what patients are typically told about nerve involvement and what the actual neurology literature documents is, frankly, one of the widest gaps we've covered on this channel. Most patient-facing materials mention neuropathy in a single sentence, almost as an afterthought next to dry eyes and fatigue. The actual clinical picture is a lot bigger than a sentence. Let's start by clearing up a mix-up that causes a lot of confusion on its own. Not all Sjogren's nerve involvement is the same condition wearing different outfits. There are actually several genuinely distinct types, and the differences between them matter enormously for how debilitating each one is and how it gets treated. The most common type is small fiber neuropathy, damage specifically to the tiny nerve fibers responsible for temperature and pain sensation. This is the tingling, burning, pins and needles version most people associate with nerve involvement in Sjogren's, and it's genuinely uncomfortable, sometimes severely painful, but it typically doesn't affect strength or coordination. If this was the only type of nerve damage Sjogren's ever caused, this video probably wouldn't need the word warning in the title. Let's actually sit with small fiber neuropathy for a moment before we move on, because even the milder end of this spectrum deserves more respect than it usually gets. Small fibers are unmyelinated or thinly myelinated nerve endings, meaning they lack, or barely have, the fatty insulation that larger nerve fibers use to transmit signals quickly. They are responsible for two very specific jobs: registering pain and registering temperature. When they are damaged, patients describe a strange mix of sensations that often don't sound like each other at all: burning, freezing, electric shock-like jolts, a persistent ache with no clear trigger, or areas of skin that feel painfully sensitive to the lightest touch, a phenomenon called allodynia, where even a bedsheet brushing against your leg can register as genuinely painful. Because small fiber damage doesn't show up on standard strength testing or basic reflex checks, it's easy for this to get written off as nothing objectively wrong during a routine exam, even though the patient's actual daily experience of it can be exhausting and, in more severe cases, seriously disruptive to sleep and daily function. But there's a second, much less talked about category called sensory ganglionopathy, sometimes called sensory neuronopathy, and this is where things get genuinely serious. Instead of damage creeping up your limbs the way classic neuropathy does, starting in your toes, slowly working upward, the textbook stocking and glove pattern every doctor gets trained to look for, ganglionopathy attacks a completely different structure: clusters of nerve cell bodies called dorsal root ganglia, sitting near your spinal cord. Damage there doesn't creep up gradually and predictably. It can show up anywhere, all at once, disconnected from any tidy pattern: your face, one hand, both feet, your trunk, with no logical progression a doctor can trace on a diagram. And critically, ganglionopathy frequently destroys proprioception, your sense of where your own body parts are in space without looking at them. Close your eyes right now and touch your nose. You can do that because of proprioception. People with Sjogren's-related ganglionopathy often can't, not because their arm is weak, but because the sensory wiring telling their brain where their arm actually is has been damaged. That leads to something called sensory ataxia, an unsteady, wide-based, almost drunken-looking gait that has nothing to do with balance organs in the ear and everything to do with lost body position sense. Real documented cases describe patients developing pseudoathetosis, involuntary, writhing movements of an outstretched arm, simply because, with their eyes closed, their brain has no idea where that arm actually is anymore. I want to walk through why this specific mechanism is so disruptive to daily life, because sensory ataxia can sound abstract until you picture what it actually means hour to hour. Think about how many ordinary tasks quietly rely on proprioception without you ever noticing. Walking down a dark hallway to the bathroom at night, buttoning a shirt without looking at your fingers, knowing how much pressure to use holding a full glass of water, catching yourself automatically when you trip on an uneven sidewalk. Every one of those depends on your brain constantly, silently tracking where your limbs are without visual confirmation. When that tracking system is damaged, every one of those ordinary moments becomes something that requires conscious, effortful visual compensation instead, and even then, it often doesn't fully make up the difference, which is exactly why falls become such a significant risk in this specific presentation. If that description just made you sit up a little straighter, type wow in the comments. I want you to really sit with that image for a second, because it's the whole reason this condition deserves a more serious reputation than it currently has. Then there's sensoromotor polyneuropathy, the second most common form, which, unlike small fiber neuropathy, does involve genuine muscle weakness alongside sensory loss, and tends to show up alongside more serious systemic Sjögren's activity, including inflammation of blood vessels called vasculitis. This form tends to progress more gradually than mononeuritis multiplex, but the end result can still be meaningful functional loss, difficulty with grip strength, trouble climbing stairs, a general sense that limbs feel heavier or less responsive than they used to, on top of the sensory symptoms laid over the same territory. There's also mononeuritis multiplex, a pattern where multiple individual nerves get knocked out one at a time, sometimes fairly abruptly, which can cause things like a genuine foot drop, the inability to lift the front of your foot, leading to tripping and stumbling, or a wrist drop, an inability to extend your hand upward at all. What makes mononeuritis multiplex particularly worth flagging is how it tends to announce itself, not as a slow, creeping numbness, but often as a sudden, almost alarming loss of function in one specific nerve's territory, sometimes overnight or over just a few days. A patient who wakes up one morning unable to lift their foot, with no preceding gradual symptoms, is describing a pattern that should immediately raise suspicion for this specific mechanism, and because it's frequently tied to active vasculitis, it's also one of the presentations that tends to demand faster, more aggressive treatment, since ongoing blood vessel inflammation can keep damaging additional nerves the longer it goes unaddressed. And rounding out the list, there's autonomic neuropathy, damage to the nerves controlling involuntary functions like heart rate, blood pressure, digestion, and sweating, which can cause dizziness on standing, chronic constipation, and a whole cluster of symptoms that rarely get connected back to nerve damage at all because they don't feel like neuropathy in the way people expect. Someone dealing with autonomic involvement might spend years being told they have just irritable bowel syndrome, or just low blood pressure, or just anxiety-related dizziness, without anyone ever connecting those symptoms back to a shared underlying cause. This is, in some ways, the most invisible form on this entire list, precisely because none of its individual symptoms look like classic nerve damage on the surface. So right there, you've got a genuine spectrum, from uncomfortable but manageable, all the way to falls, dropped feet, and involuntary limb movements. And here's the number that should stop you. Research consistently finds peripheral neuropathy in somewhere between 10 and 20% of primary Sjögren's patients using standard testing, though some studies using more sensitive detection methods have found signs of nerve involvement in a much larger share of patients than that. This is not a rare footnote complication. It's a meaningful chunk of the entire Sjögren's population, quietly living with a level of nerve damage most people, including a lot of patients themselves, have no idea is even possible with this disease. If you've been told your neuropathy is just part of having Sjögren's without ever getting a clear explanation of which type you actually have, type unclear in the comments. That distinction matters more than almost anyone tells patients up front. Now here's the part that genuinely owns the word warning in this video's title. This specific form of nerve damage gets missed, misdiagnosed, and delayed far more often than it should, for reasons that are almost built into how neurology training works. Standard nerve conduction studies, the tests most doctors reach for first when investigating numbness or tingling, are specifically designed to detect damage in larger, well-myelinated nerve fibers. Small fiber neuropathy, by definition, involves the tiny fibers those standard tests can't see at all, so patients can have a completely normal nerve conduction study while still experiencing very real, often severe neuropathic pain, which then sometimes gets written off as anxiety, fibromyalgia, or nothing objectively wrong, when what's actually needed is an entirely different test. A small skin biopsy specifically counting nerve fiber density, something a lot of general neurologists don't reach for as a first-line option. Ganglionopathy has its own, arguably worse, misdiagnosis problem. Because it doesn't follow that expected stocking and glove pattern, and because it often develops slowly and insidiously rather than dramatically, it frequently gets mistaken for a completely different condition called CIDP, chronic inflammatory demyelinating polyneuropathy, which is treated differently, or in some documented cases, gets dismissed entirely as a functional or psychiatric movement disorder, because doctors unfamiliar with this specific presentation see unsteady gait and strange limb movements with no obvious weakness on exam and reasonably, if incorrectly, start looking in the wrong direction entirely. And here's a statistic that deserves its own spotlight. In one detailed clinical cohort studying Sjogren's related peripheral neuropathy, researchers found that the neuropathy symptoms actually came before the formal Sjogren's diagnosis in roughly 1 in 5 patients. Read that again. The nerve damage showed up first, years sometimes, before anyone connected it to an underlying autoimmune disease at all. That's not a minor detail. That's potentially years of unexplained numbness, pain, or unsteady walking, in patients who had no idea an autoimmune disease was quietly driving all of it. If you've experienced nerve symptoms that came before, or completely separate from, the classic dry eyes and dry mouth, type missed in the comments. This exact gap between the nerve symptoms showing up and the actual diagnosis landing is one of the most underappreciated parts of this whole disease. There's also a genuinely surprising demographic wrinkle worth mentioning here. Sjogren's overall skews heavily toward women, roughly 9-1. But one detailed study specifically looking at severe Sjogren's-related neuropathy with limb weakness found something different. A median age of 63, and, unlike the disease overall, a roughly even, 1-to-1 split between men and women. That matters clinically, because if a doctor is mentally filtering probably not Sjogren's based on a male patient's gender alone, in this specific, more severe neuropathy presentation, that assumption may be actively working against an accurate diagnosis. Okay, let's talk treatment, because I don't want to leave you with just a list of scary possibilities and no path forward. The honest, upfront truth is that treatment for Sjogren's-related neuropathy doesn't have one single, universally agreed upon standard protocol the way some other complications do. Most of the evidence comes from smaller case series and retrospective reviews rather than huge randomized trials, largely because this specific complication, while more common than people realize, still isn't common enough to easily run massive clinical trials on. That's a real limitation worth being honest about. But within that limitation, there's genuinely useful data. One pooled review looking across more than 6 patients found that intravenous immunoglobulin, or IVIG, produced clinical improvement in the large majority of cases, with most of the remaining patients at least achieving disease stabilization rather than continued decline, and it appeared to help across sensory, motor, and mixed sensoromotor presentations, which is genuinely encouraging given how many different flavors of this nerve damage exist. Rituximab, the same B-cell depleting medication used for other severe Sjogren's complications, has shown more variable results across different studies. Some cohorts report response rates as low as around a third of patients, while others report meaningful improvement or stabilization in closer to 3/4, with response appearing to depend heavily on which specific type of neuropathy is being treated, and sensoromotor and pure sensory forms generally responding better than others. For mononeuritis multiplex specifically, that pattern of individual nerves getting knocked out, often tied to vasculitis, cyclophosphamide has shown a genuine ability to stabilize the condition and prevent further nerve loss, even if it doesn't always reverse damage that's already occurred. And for the most severe, vasculitis or cryoglobulinemia-associated cases, treatment often gets escalated quickly and aggressively, combining high-dose steroids with rituximab or cyclophosphamide right out of the gate, rather than working slowly up a gentler treatment ladder, because the tissue damage in these more aggressive presentations can progress fast enough that a cautious, step-by-step approach risks losing ground that's hard to get back. One thing worth flagging honestly, not every treatment tried for this condition has panned out. Methotrexate combined with steroids, for instance, has not shown clear effectiveness for Sjogren's-related peripheral neuropathy in the available data, despite being a reasonable first guess given how useful it is for joint symptoms in this same disease. That's a good, humbling reminder that what works well for one manifestation of Sjögren's doesn't automatically transfer to another. The joints and the nerves are simply not the same battlefield. If knowing there are actual, research treatment options, even without one perfect universal protocol, gave you a little more hope than you walked in with, type hope in the comments. This isn't an untreatable mystery. It's a genuinely researched, genuinely treatable complication that too often just isn't recognized quickly enough. Let's clear up a few myths before we wrap this up, because I can feel a couple of wrong conclusions forming out there. Myth: neuropathy in Sjögren's is always just uncomfortable tingling, nothing more serious. Reality: as we just spent a good chunk of this video proving, that's true for some patients and dramatically untrue for others. Ganglionopathy and sensorimotor polyneuropathy can cause genuine, measurable disability, falls, dropped feet, loss of fine motor coordination, not just discomfort. Myth: if my nerve conduction study came back normal, that rules out Sjögren's-related nerve damage. Reality: standard nerve conduction studies are specifically blind to small fiber damage. A normal result rules out large fiber involvement. It says essentially nothing about small fiber neuropathy, which needs its own dedicated test, a skin biopsy checking nerve fiber density, to actually evaluate. Myth: nerve damage in Sjögren's always shows up after the dry eyes and dry mouth are already diagnosed. Reality: we just walked through real data showing neuropathy symptoms preceded the Sjögren's diagnosis in roughly 1 in 5 documented cases. If you're dealing with unexplained numbness, pain, or unsteady walking with no diagnosis attached yet, Sjögren's absolutely deserves to be on the list of things worth ruling out, even without the classic dryness symptoms present yet. Myth: since it's mostly untreatable and poorly understood, there's not much point pursuing an aggressive workup. Reality: quite the opposite. The treatment data we just covered, while imperfect, shows real, meaningful improvement is achievable for the majority of patients with the right therapy matched to the right neuropathy subtype. The bigger risk isn't that treatment doesn't exist. It's that the diagnosis takes too long to arrive for treatment to even start. If any of those myths was something you genuinely believed before this video, type learned in the comments. Every one of these misconceptions has real consequences for how quickly someone gets properly diagnosed. Let's do a quick round of rapid-fire questions before we close out. How do I know if my tingling is just small fiber neuropathy or something more serious like ganglionopathy? The biggest tell is whether it's affecting your coordination and balance, not just sensation. Ordinary small fiber symptoms are typically pain, burning, and altered sensation without weakness or unsteadiness. If you're also noticing clumsiness, difficulty with fine tasks like buttoning a shirt, or unsteadiness that gets dramatically worse with your eyes closed, in the shower, for instance, or in the dark, that's a meaningfully different pattern worth flagging specifically as possible ganglionopathy to whoever's treating you. What kind of doctor should actually be running these more specific tests? A neurologist, ideally one with some familiarity with autoimmune-related neuropathy, working alongside your rheumatologist. A skin biopsy for small fiber density and a full neurological exam checking proprioception and reflexes are things a general practitioner typically won't have on hand, so a referral is usually the right next step rather than something to try to sort out at a routine physical. If I already have a Sjögren's diagnosis, should I be screened for this even without obvious nerve symptoms yet? It's a reasonable question to raise with your rheumatologist, especially given how insidious and easy to miss early ganglionopathy symptoms can be. A basic neurological exam checking reflexes, vibration sense, and proprioception is quick, low risk, and can catch early changes before they progress into something more disruptive. Is this kind of nerve damage permanent once it happens? It genuinely depends on the type and how early treatment starts. Some of the case data we covered showed real, sometimes dramatic improvement with prompt treatment, but delayed treatment generally correlates with a harder road to recovery, which is exactly why early recognition carries so much weight here, more than in some of Sjögren's other complications. Here's what I want you to walk away with. Sjögren's-related nerve damage has a reputation problem. It gets talked about, when it gets talked about at all, as a footnote, some tingling, a little numbness, nothing that changes the bigger picture. The reality, backed by real clinical research, is a genuine spectrum that on its more severe end includes real disability, falls, dropped feet, loss of coordination, involuntary limb movements. That's not meant to frighten you if you're dealing with mild symptoms right now. Most people with Sjogren's-related neuropathy live with the milder end of this spectrum. It's meant to make sure that if you, or someone you love, is dealing with the more severe end, it gets recognized for what it actually is, quickly, instead of being quietly filed under just some tingling for years while a treatable condition keeps progressing. If this helped you understand your own symptoms a little better, or gave language to something you or someone you know has been struggling to explain to a doctor, share it with them. This is exactly the kind of gap between what patients are told and what the actual research shows that this channel exists to close. And if you want to see exactly how this connects to the bigger picture, go watch 20 internal body parts Sjogren's can damage right after this one. Neuropathy is one of the 20, and that video walks through where this fits alongside everything else this disease can quietly reach. Type next in the comments once you've watched it and tell me which one of those 20 you want a full deep dive on next. Take your nerves seriously, take your symptoms seriously, and take yourself seriously enough to ask for the specific tests that actually look for this. I'll see you in the next one.